All right, let's jump right into it. Today, we're stepping into the shoes of a clinical detective to master urology. And look, we're not just going to sit here and memorize dry facts, right? We're going to look at real clinical presentations, examine the clues, and most importantly, figure out the anatomical why behind the symptoms. By the time we wrap up this explainer, I promise you're going to see the urinary tract as this fascinating, just brilliantly engineered system. Okay, let's dive in.
So, here is our roadmap for today's clinical investigation. We'll be breaking this high-yield diagnostic journey into 5 acts: decoding urinary tract symptoms, managing complex UTIs, prostate pathology workups, the hematuria warning signs, and finally, anatomy and reflux mechanisms.
Act 1. Decoding urinary tract symptoms.
To get our foundational language down, let's start with our first case. You've got a 40-year-old patient complaining of urgency, nocturia, frequency, and urge incontinence. So the core diagnostic question is, which category of lower urinary tract symptoms, or LUTs, does this actually fall under? Is it upper tract, storage, voiding, postmicturitional, or just all of the above?
Well, the correct answer is B, storage lower urinary tract symptoms. The pathophysiology here is honestly pretty fascinating. These specific symptoms, the urgency, the frequency, getting up at night, the urge incontinence, they're all irritative. They basically show that the urinary bladder just can't retain urine smoothly at low pressures anymore. Classically, this points straight to an overactive detrusor muscle or maybe reduced bladder compliance.
So this builds out our entire diagnostic framework into 3 clear phases. We've got our storage phase, which we just talked about. Those are your irritative symptoms. But then we have the voiding phase. Symptoms like hesitancy, a poor stream, or having to strain. Those are obstructive. They imply there's a literal mechanical roadblock in the way, kind of like benign prostatic hyperplasia. And finally, we have postmicturitional symptoms, like incomplete emptying or dribbling after the fact. That tells us urine is pooling up, maybe in the bulbar urethra, or the detrusor muscle just isn't squeezing it all out.
Moving right along to Act 2, managing complex UTIs. We're shifting focus to acute scenarios now, where making the wrong move can actually be super dangerous. Think about this case. We have a 54-year-old diabetic male who's been having recurrent infections ever since a transvesical prostatectomy 2 years ago. He comes in with burning micturition, increased frequency, and dysuria. His urinalysis is lighting up with white blood cells and 40 to 50 red blood cells per high-power field. So, out of these options, what is the absolutely mandatory next step?
The answer is E, urine culture and sensitivity. Here's a massive exam pearl for you. Any UTI in an adult male is considered complicated until proven otherwise. And because this patient is highly inflamed right now, invasive structural investigations like a cystoscopy are completely off the table. I mean, doing one could literally push bacteria into the bloodstream and trigger urosepsis. You have to follow this exact sequential workflow. First, get the culture. Second, immediately start empirical broad-spectrum antibiotics. Third, just wait. Let the active infection and local inflammation totally settle down. Then and only then, at step 4, can you do your elective diagnostics like a cystoscopy.
Speaking of complex infections, let's look at another tricky one. Imagine a 35-year-old neurosurgical ICU patient who's had a Foley catheter in for 6 weeks. His urinalysis comes back with a massive 10,000 white blood cell count, but here's the catch: 0 fever. No systemic signs at all. This is the perfect example of sterile pyuria versus a true Coyote, or catheter-associated urinary tract infection. Look, long-term catheters are going to cause a foreign body reaction. It's inevitable. If there are no systemic symptoms, throwing antibiotics at the sterile pyuria is just going to breed resistance. You literally just remove or swap out the catheter. You only bring in the 7 to 14 days of targeted antibiotics if it's a true Coyote, meaning they have systemic criteria, like a fever spiking over 38 degrees Celsius.
Now, what if a post-op patient develops a genuine, symptomatic, but uncomplicated hospital-acquired UTI right after early catheterization? Well, the magic number here is 3 to 5. A streamlined 3 to 5 day course of highly concentrated urinary antibiotics is the sweet spot when you're dealing with classic bugs like E. coli. And of course, pull that catheter out immediately.
Act 3. Prostate pathology workups.
Let's explore how we handle inconclusive cancer screenings. Here's our next mystery. A 60-year-old guy suspected of having prostate cancer. He had a standard transrectal ultrasound, or TRUS-guided biopsy, but it came back totally inconclusive, even though his PSA keeps steadily rising. Because of that, a transperineal template biopsy is planned. Typically, how many core biopsy samples do we actually need for this approach?
The right answer here is E, 36.
When that first transrectal biopsy just completely misses the mark, you escalate to the transperineal template biopsy. This procedure uses a really systematic brachytherapy-style grid layout. It literally maps out the entire prostate, and to do that comprehensively, you're usually collecting around 36 individual core samples.
And here's exactly why this is such a game changer. Your standard TRUCE-guided biopsy through the rectal wall, it only grabs about 10 to 12 cores, and it has a huge anatomical blind spot. It really struggles to reach the anterior zone of a large prostate. Plus, there's a higher risk of sepsis because, well, you're dragging rectal flora directly into the tissue. The transperineal approach, on the other hand, takes those 36 cores, gives you incredible, exhaustive coverage, especially of that tricky anterior zone, and has a much, much lower infection risk.
Let's quickly loop back to our 54-year-old diabetic patient from Act 2, the guy with the recurrent post-prostatectomy UTIs. Remember how we said you got to treat that acute bacterial phase first? Okay, well, once that infection is completely wiped out with antibiotics, flexible cystoscopy becomes the absolute gold standard. Those recurrent infections are a massive red flag, pointing to a structural issue like bladder neck stenosis or an anatomical stricture. You need that cystoscope to go in, visualize the lower tract all the way up to the bladder neck, and find that mechanical why.
Act 4. The hematuria warning signs.
All right, we are officially shifting to high alert now, because whenever a patient tells you they have blood in their urine, we have to meticulously rule out malignancies. Picture a 50-year-old male presenting with 6 months of recurrent, painless, gross hematuria. They've had non-invasive imaging, an ultrasound, an X-ray KUB, and both come back totally normal. Inconclusive. So what crucial investigation has to happen next?
The answer is D, cystoscopy. This is one of those golden rules in urology you absolutely cannot forget. Painless, gross hematuria in any adult over 40 is a urothelial malignancy, usually bladder carcinoma, until you definitively prove otherwise. I don't care if the ultrasound was perfectly normal. Standard imaging easily misses tiny flat lesions, carcinoma in situ, or small papillary tumors. Direct visualization with a flexible cystoscopy is literally mandatory here.
If you want a great diagnostic clue, ask about the exact timing of the bleeding. The precise moment blood appears in the urinary stream is a fantastic proxy for exactly where it's coming from anatomically. If a 60-year-old tells you the blood is only there at the very start of the stream, that's initial hematuria, which points to a urethral issue. If it's total hematuria, just evenly mixed throughout, that points higher up to the bladder body or upper tract. But if the blood only shows up right at the very end, terminal hematuria, that strongly implicates a lesion at the bladder neck, the trigone, or the prostatic urethra getting squeezed out as the bladder muscles clamp down at the end, avoiding. And once again, that dictates a structural check via cystoscopy.
Finally, Act 5, Anatomy and Reflux Mechanisms.
Let's really zoom in on the physical mechanics of the lower urinary tract for a second. We've talked about cystoscopy a bunch, but how do we actually navigate it? Entering the bladder neck to find the ureteral orifices takes some real anatomical precision. After passing the urethra, you have to advance the probe anteriorly and superiorly, or cephalad, to physically lift it past the anatomical lip of the bladder neck. From there, you map the trigone to find that interureteric ridge where the orifices actually sit. And to finish, you do the J maneuver. You literally curve the scope back around on itself into a J shape to clearly see that tricky blind spot right behind the bladder neck.
Speaking of those ureteral orifices, let's talk about the incredible engineering that stops urine from backing up and destroying your kidneys. In healthy individuals, which of these mechanisms actively prevents vesicoureteral reflux, or VUR, up into the upper tract?
The answer is C, compression of the intramural portion of the ureters. Guys, this is just a brilliantly simple, passive, one-way valve right at the ureterovesical junction. The ureter enters the bladder wall at an oblique angle, forming a little tunnel surrounded by detrusor muscle. So as the bladder fills up, the pressure inside expands, and those muscle sheets flatten out, physically squishing that intramural tunnel closed. But for this to work, there's a strict 5-to-1 ratio rule. The length of that tunnel has to be at least 5 times its internal diameter. If someone is born with a tunnel that's too short, that mechanical valve just completely fails, and you get primary VUR.
Which brings us perfectly to our final takeaway. Vesicoureteral reflux is actually the most common underlying cause of UTIs in children. We find it in about 35% of kids who present with recurrent febrile UTIs. Usually, they need long-term, low-dose prophylactic antibiotics just to protect their developing kidneys while we wait to see if it spontaneously resolves. And honestly, this perfectly sums up our entire journey today as clinical detectives. Always treat the underlying anatomical cause, not just the surface symptom. So next time you come across a puzzling clinical presentation, I want you to ask yourself, what hidden mechanical failure is driving this? Thank you so much for exploring this incredibly fascinating topic with me, and I'll catch you on the next Explainer.